Ladies and gentlemen, in this instruction course on femtosecond laser assisted cataract surgery, I shall be talking about pupil management. Pupil management of a small undilated pupil is usually required at two places during Flacs. One is at the beginning of surgery. Like any other surgery, small pupil is obstructive to proceed with cataract surgery. The second time where pupil may constrict, even a dilated pupil may constrict, is just after the application of the laser. Preoperative pupillary meiosis is usually dealt with as in any other case by the use of NSAIDs preoperatively, both on the previous day and the day of the procedure, and the use of cycloplegics both during the procedure and before the surgery. So all this basically decreases the amount of prostaglandins that are released into the aqueous, as well as causes a dilatation of the pupillary sphincter. Pupil distortion in a patient who is about to undergo laser cataract surgery can be managed by slightly adjusting the capsule rhexis in such a way that it corresponds to the pupillary area. For example, you can see over here that the pupillary margin encroaches into the region of the capsulotomy, because of which the capsulotomy has been shifted slightly and temporarily so that it is not obstructed by the pupil. In a very small pupil, I usually prefer to do no rhexis or any procedure below the cornea so that I stick only to corneal incisions, of course, after informing the patient. Here you can see that the OCT shows only the presence of corneal incisions and we are not going below the corneal plane. There is also the possibility of decreasing the size of the rhexis in a small pupil. So your regular 5.2 or 5.5 millimeter rhexis can be brought down to around 4.6 or 4.7, but going below that would be detrimental. So to that, provided you're clearly away from the iris margins while doing the procedure, which is well indicated by this OCT here. There should always be a watch out for iris bleed in a small pupil. You can see here at the 10 o'clock position, there is collection of heme. Along with heme, which is usually restricted because the eye is not opened till the wounds are open, and therefore the intraocular pressure maintains the blood to a minimum. There could also be a capsular adherence in the region because the laser was never able to penetrate through the iris to the capsule. Now here we have a tag at that end, and we also see that the capsule is attached to the rest of the anterior lens capsule at the inferior margin of the iris as well. So all these attachments need to be gently cleared off before drawing the capsule out. Now, whatever tag is left in the region of the 10 o'clock position has to be gently peeled off so that later on it does not extend to become a posterior capsular rect. In case of an undilated pupil preoperatively, mechanical form of dilatation of the pupil is also possible using Malyogan rings. In this situation, you make a main port incision, pass the ring, uniformly dilate the pupil, wash out the viscoelastic, and then suture the incision before sending the patient into the laser machine. So now you have a nicely dilated pupil that can be subject to all the corneal, laser, and lensectomy procedures that are included in the gamut of femtosecond cataract surgery. During the procedure, you try to avoid making a main port incision because that already has been made. The rest of the laser incisions are made. And after the laser procedure, the suture is removed and all the routine procedures of phacoemulsification are carried out. Basically, the intraoperative meiosis that happens after application of the laser is proportional to the laser energy used. Nowadays, we use a lesser amount of energy because of which that has ceased to be the cause. It also increases with increased laser duration, in the sense that if you're doing too many cubes or too many cylinders or too many chops in the lens, there's a higher chance that you would get a constricted pupil. So it's better to stick to the prescribed regimen for each type of cataract. So if you have a low density of the nucleus, maybe better to just go for 4 quadrants instead of 6 wedges. It also increases with when the pupillary margin is close to the intended capsulotomy. Another reason for post-laser meiosis is also said to be a delay between the laser pre-treatment and shifting of the patient for surgery. So these are all situations that can be controlled to some extent, and therefore it is slightly easier to treat post-laser intraoperative meiosis. Now, in case the parameters of the laser cannot be controlled, of course, the management goes into the pharmacological zone. We can use any combination of epinephrine and lignocaine or tropicamide and lignocaine, and now you have phenylephrine combined with ketorolac, all for dilating the pupil pharmacologically. Mechanical dilatation is tried when pharmacological fails, and this can be done either by the soft shell technique using viscoelastics or by using different hooks and rings, as you have seen before. So these are the two situations where the pupil needs to be managed in femtosecond laser assisted cataract surgery, and I hope this has been helpful. Thank you very much.